Hello, and welcome to our session today, Palliative Care in Manitoba, Urban versus Rural. We have three presenters with us today. Our first presenter is Mike Goldberg, who has been the Community Outreach and Education Coordinator at Palliative Manitoba since July 2015. He received his bachelor's in psychology from Winthrop University in South Carolina and master's in gerontology from the University of Regina. Mike facilitates bereavement education seminars across the province for organizations wanting to improve their understanding of the palliative care approach, and he facilitates compassionate care courses for the WRHA healthcare attendants, direct support workers, and First Nation communities. Mike is also the primary facilitator for Palliative Manitoba's grief support groups for children, kids to grieve, and teens grieve too. And we also have Ogechi Asagwara, is the clinical nurse specialist with the WRHA Palliative Care program in Manitoba. She works within the interdisciplinary care team to support the comprehensive needs of individuals and their families receiving palliative care. She is involved in clinical consultations, education, policy development, and professional leadership. She is passionate about meeting the unique needs of this patient population and recognizes the importance of living well across the lifespan, including at the end of life. Brenda Smith has been nursing for 35 years, the first 10 years spent at Brandon Regional Health Center in a variety of acute care and long-term care settings. She began with the home care program in 1997 as a direct service nurse and continued in that role until 2015, when she became a clinical resource nurse for the PMH Regional Palliative Care Program. She received the Hospice and Palliative Care Nursing Certificate in 2006. She has completed the Pallium Canada LEAP course and has done some presentation for Pallium in the local WRHA. In her spare time, she enjoys gardening, knitting, and spending time with family. Thank you, everyone, and you can continue.
Well, thank you so much, Sharon, and everybody at the Canadian Pulmonary Fibrosis Foundation for inviting us to present on palliative care in Manitoba. I'm very excited to be here with my colleagues Ogechi and Brenda. And what we're going to do today, we're going to start by talking a little bit about palliative care, the palliative care approach, the philosophy of care. I know that with this webinar series that you've been running, you've been hearing a lot about palliative care, and I think a lot of it is going to be review, and that's okay. We'll just briefly touch on what palliative care is. I'd also like to talk a little bit about my nonprofit organization, Palliative Manitoba, and the volunteer support that we provide. And then after that, Ogechi is going to provide the urban perspective from Winnipeg, in the Winnipeg Regional Health Authority Palliative Care Program, what that looks like. And then we'll transition to provide a more rural perspective, and Brenda Smith will talk a little bit about how palliative care is delivered in the Prairie Mountain Health region in Manitoba. So thank you again for having us. And I always really appreciate the opportunity to talk about palliative care, and specifically the palliative care approach, because it really isn't discussed a lot, when we're thinking about providing healthcare in our system, generally, because people often couple the idea of palliative care with death and dying, and of course there's this the stigma attached to this idea of death. We really, view ourselves as sometimes being immortal, that we don't have to address the idea of our mortality. But it is a fact of life, and especially here in Canada. Sometimes it's described, our culture here as being death denying. We don't really like to talk about it, and particularly we don't like talking about death and dying with our young people, with our children. Sharon mentioned that I facilitate a grief support group for kids and teens, and one of the benefits of that group is exposing kids and teens to this idea that we can talk about death openly and directly, and really that is the ideal way to heal from loss, no matter your age, is to address your bereavement head on, and talk about your emotions directly. So it really is a taboo subject, and I do appreciate every opportunity I get to advocate for a more grief, a more death literate society. Why is it that we live in this kind of society? Well, really, death doesn't really take place at the home and in front of our eyes, and like I mentioned, in front of our kids and children's eyes. Most deaths do occur at hospital, away from the home and the family. So that certainly could be one of the reasons. But also, we are living much longer. Like I said, maybe we consider ourselves to be immortal with the organ transplants and donations and technology that is constantly being enhanced, and medical technology is always advancing. So really, we do avoid these conversations about end of life. Most people do not have conversations about advanced care planning as much as they should, even though if we have some kind of accident or develop some kind of illness tomorrow, those conversations are it's honestly too late to have those talks. So really the best time to talk about death and dying, even though it's so very difficult, is right now. And that kind of brings us to this idea of palliative care. And as we go through this definition, I want to highlight a few important aspects of it, and then we'll dive a little deeper into some of the core tenets of palliative care. So really, right off the bat, you notice, and again, this is from the World Health Organization. Different organizations and different entities around the world, they define palliative care in their own way, but this is from the WHO, and so it defines palliative care as an approach, first and foremost, and really that's what we're going to be talking about today, as a philosophy of care. Of course, like I mentioned, we're going to hear from Ogechi, who works in a palliative care program, and that is distinguished from just using an approach to care. It's actually a place of care. But right now, I just want to talk a little bit about the approach to palliative care, and really what it focuses on is enhancing the quality of life of not only individuals who are approaching end of life, or they have a life-limiting or life-threatening illness, like cancer, but not only them, but their families around them, the people around them. And that's, I think, what makes it somewhat unique from the conventional or traditional healthcare system, which is more focused on just getting people in and out of the beds, and making sure that there's efficiency in the program. This focuses on the health, well-being, and quality of life of not only the individual, but the families around that person. Of course, how do you do that? You do it by preventing and relieving suffering, and so really focusing on pain management of that individual. And so what really is pain, though? Because most people think about pain as being just a physical phenomenon, but there's so much more to pain that needs to be addressed, that the human being experiences. Of course, that involves psychological pain, social pain. When we're talking about social pain, we're referring to this idea of isolation, something that we've really been made aware of, or especially during this pandemic, it has revealed itself to be a major issue in our health systems, where people are approaching end of life and not being able to see their loved ones or say goodbye, or participate in that kind of ritual, and of course spiritual pain, feeling this existential dilemmas at end of life, a loss of meaning and purpose. These are all pain. This is all pain that needs to be addressed, and that is what the palliative care approach. If physicians and nurses and social workers and spiritual health practitioners, they utilize the palliative care approach, that is what they are addressing, is that idea of total pain. So going into some of the principles of palliative care, some of the core palliative care, some of the core tenets of palliative care, again, to reiterate, the approach to care is attempting to relieve pain and other distressing symptoms, from this life-limiting or life-threatening illness that an individual might have. And again, most people, look at this idea of death and dying as another illness that needs to be stopped in and of itself. But really, if you're utilizing the palliative care approach and professionals and volunteers, that work in and around palliative care, they look at this idea of life and death as just a normal process, an organic process that should take place in a normal fashion without too much intervention. And we'll hear more about what that criteria is when we get into more specific programs, palliative care programs, what kind of admission criteria there is in terms of not using that kind of intervention. When we're thinking about palliative care, we're not looking to hasten or quicken the dying process or postpone death. So again, a misconception might be that if we're looking to sometimes manage pain and provide say morphine to an individual who's experiencing that kind of physical pain, a misconception may be that morphine hastens death, and that is not definitely not the case. Again, palliative care professionals are just looking to enhance the quality of life, and by doing that, you can reduce pain by providing those types of medications. But again, the goal is not to hasten or postpone the dying process. And of course, we're looking at total pain, right? So the psychological aspects of pain, spiritual components of patient care. So looking at the whole person, not just as as their illness, but focusing on what's meaningful to the person. Who is this person? What is important to them, and how can we support them? Socially, psychologically, and spiritually, of course. When we're supporting somebody in palliative care who's approaching end of life, the goal is to allow them to live, right? We're talking about a life affirming procedure and service. So what does that mean? It's going to look different for every individual. For somebody who really is an active and person who might like and have enjoyed sports in their life, but their illness has debilitated them, and they're not maybe able to do or perform the acts that they once used to do. Maybe a part of supporting them and enhancing their life is having conversations about sports, or allowing them to see the sports that they really enjoyed playing, or just doing little things, just passing a balloon back and forth to them to allow them to feel that kind of dexterity and athletic ability that maybe they once had. We're also talking about, like I mentioned, this support isn't just for the individual who is approaching end of life, but it's for the family and people around the individual who care about that person. And it includes grief and bereavement support. Another misconception is once that person dies, support, palliative care just stops intervening, stops supporting that circle, and couldn't be farther from the truth, as we'll hear from Ogechi talking about some of the procedures, including social workers after a death has occurred, and for my organization as well, it's important to support people as they're moving through the grief and bereavement process. And of course, we do this by incorporating the team, the interdisciplinary team of people who are working to support the individual and the family. So that is, of course, physicians, nurses, social workers. It could be speech language pathologists, nutritionists, spiritual health practitioners, of course, direct healthcare aides, direct support workers, and volunteers as well. So an interesting part about palliative care is sometimes when somebody is on a palliative care program or being supported or cared for by an individual utilizing the palliative care approach, is that their quality of life is enhanced, and it may allow them to live a little bit longer. It may influence the life course in that way. Again, the goal isn't to hasten or postpone death, but that is sometimes a natural consequence of having an enhanced quality of life. Again, we're trying to get to know individuals, who they are, how they define themselves, how they make meaning in life, and that includes understanding what kind of cultural background they're in, allowing them to feel culturally safe in this caring environment, being sensitive to their religious and spiritual beliefs as well. And again, this is the palliative care approach. People who are professionals, volunteers who utilize it, understand and respect the individual autonomy and dignity of somebody who is approaching end of life. So getting to know, what a good death actually is for this person, because if you ask that question to somebody, you're never going to get the same response. So that's something that we really need to be curious about as we're supporting people who are approaching end of life. And probably the most important part about the palliative care approach is that it should be available regardless of your choice of setting. So as we'll go into, as Ogechi will talk a little bit about some of the statistics of where people are receiving palliative care. Oftentimes we have to support people in their home. We don't really have the resources to and the building, the brick and mortar to facilitate that kind of palliative care approach right now in Canada. And so it has to be done wherever the individual is aging and approaching end of life. So oftentimes that's in the home. It could be a personal care home. It could be a hospital as well. In Winnipeg, we have 2 palliative care units and 2 hospices, so that it is achieved there as well. But it should be available regardless of the choice of setting. Some of the overall benefits of palliative care, some of the more tangible benefits that we can talk about is something called the Compassionate Care Benefit, which is a federal program, federal EI benefit for people who are supporting their family member who's very ill from life-threatening illness. They may have to take time off of work to provide this kind of support, and they're eligible to receive 26 weeks of pay based on this compassionate care benefit. Also, when you are registered on a palliative care program across the country, we have something called the Palliative Care Drug Access Program. So, during the course of their end of life, the drugs that are necessary, the pharmaceuticals, pain management that is necessary to take care of you as you're approaching end of life, that is also covered, by the government. And if you are registered in the drug access program, you do have access to palliative care home oxygen as well. So, that is coupled with the drug access program, then you are eligible, if you require it, to have oxygen in your home or wherever you're aging. Just kind of summarize this idea of palliative care into a quote, and this is from Dame Cicely Saunders, one of the founders of the modern hospice and palliative care movement, is: you matter because you are you. You matter to the last moment of your life, and we will do all we can not only to let you die peacefully, but to help you live until you die. Really stressing this idea of life, enhancing the quality of life at end of life, even though sometimes it feels like we can't really think about who we are or what makes life worth living as we're approaching end of life. Sometimes we're just consumed with this idea of death and dying, but really the idea of palliative care is to enhance that personhood and quality of life up until that moment of death. So just briefly, I just want to touch on what my organization does, Palliative Manitoba, and our goal is to ease the suffering of dying and the bereaved and caregivers throughout Manitoba by providing supported services and education. And really what our goal is, in the future, is that people throughout Manitoba are connected with information and support when facing death or grief. And so who are we? We're really a volunteer based organization. We do have 8 staff members, including myself, but the volunteers that we have over 125 active volunteers, and that's really the backbone of our organization and what we do. We've been around since 1983, providing support and services and education. We receive funding from the United Way of Winnipeg, also the WRHA, but the majority of our funding comes from donations and requested grants and fundraising events that we do. And we're located here in Winnipeg at Deer Lodge Health Center. So just a quick overview of some of the things that we do, including bereavement support. One of our most used programs is a telephone bereavement support program that anybody across Manitoba can access. We can connect you with a trained volunteer to talk with you over the phone. For at the longest 1 year. It's a free service, If you do require the service after a year, we generally look to end that match and provide you with another volunteer, just to look out for the the safety and the self-care of the volunteer. But it's a wonderful service, free telephone bereavement support. As Sharon mentioned off the top, I facilitate kids and teens grief support groups. So that's 2 grief support groups a year. They're closed groups, 6-week groups. And we just allow kids and teens to get to know themselves a little better, acknowledge their grief and loss directly, understand emotions in a more intimate way. And we also have a separate program for the parents and guardians that we offer as well, because losses and the grieving experience, it doesn't necessarily happen in isolation, right? We have educational grief seminars where we recruit expert speakers to come talk about grief, and again, to create a more grief literate society. We have a memory tree that right now we're doing online. It's a virtual memory tree because of the pandemic, where people can write in and write a card in honor of a person that they've lost and send it to us, and we create a virtual tree. But in non-pandemic times, we have an actual tree in one of our malls here in Winnipeg that people can come visit. We have trained volunteers that they can talk to there as well. We have end-of-life visiting support. So all our volunteers provide supportive presence for people who are approaching end of life, and in the WRHA Palliative Care program. It's here and again, Ogechi will mention the palliative care units here and the hospices, and our volunteers are able to visit people, provide respite for family members at home as well. And of course, we offer education. We try to advocate for the palliative care approach like we're doing right now, and we train our volunteers. We are a compassionate care course. It's a 10-week course, and it's open to the public as well. So we're just trying to train people on about palliative care and understanding death and dying in a more direct way. And we have an annual provincial palliative care conference too that brings people from all across the country together to learn about the more recent findings in the palliative care field. So that's who we are. We're trying to change the conversation about death and grief, and now we're going to transition into a conversation about the WRHA Palliative Care Program, more urban look about what we're doing here in Winnipeg in terms of palliative care services. And I'll pass the baton over to my colleague, Ogechi.
Thanks, Mike. So I'm just going to do a really quick overview of the palliative care program based in Winnipeg. I'm just, in the interest of time, going to try to hit the highlights, keep it short and sweet. Next slide. So in the province of Manitoba, there is 1.38 million people. There is a large concentration of that total population within the city of Winnipeg, where the WRHA, Winnipeg Regional Health Authority, provides health services to the population. Winnipeg is in red there, kind of represented at the bottom of the map. Across the entire province, we have 5 health authorities that exist and provide health services to residents in their geographical area. And we also recently have the addition of Shared Health, which is a province-wide health authority to help with the centralization of resources across the entire province. We also provide, so we do have the formal palliative care program. Just next slide, please, Mike. So in addition to the formal palliative care program, we actually also offer strictly consultation services. So this is available to anybody, and it's available across the province. So enrollment on our formal program is not required. And if you're within the WRHA region, we can see you in person, or sometimes even by phone if that's necessary. And if you're outside of the WRHA catchment area, so the larger province, then you have access to our consultation services by phone. The provincial phone service is physician-to-physician consultation. So a doctor can call up one of our palliative care physicians, review questions and concerns by phone, and get direct suggestions for care that way. And again, if you're local within the WRHA region, we try our best. The preference is actually to see the individual in person. Those visits are conducted by the clinical nurse specialists like myself, and also the palliative care physicians kind of work together to meet all the consultation needs across the region. Again, enrollment on our formal program is not required, and actually many of the rural health authorities don't actually have a designated palliative care physician within their region, so we do get quite a volume of calls from the provincial groups for care and suggestions in their palliative care patients. So we see and assess patients and provide clinical guidance, medication suggestions, recommendations for care wherever they are across the region. We work alongside the involved care team and can follow someone for a period of time until their immediate needs, symptoms, issues are resolved, and then we would sign off on care. This consultation service being available really helps support, as Mike was talking about, that palliative approach to care, so that any patient who needs palliative care support or insights in their care can access it, regardless of if they fit really nicely into that kind of necessary criteria for enrollment on program. So which is what I'm talking about on the next slide, actually. So aside from consultation, we have our formal program. So we do use eligibility criteria to help us try to distinguish who's at most need for sort of the insulative support that the program provides at any given time. Ideally, we'd like to support everybody who could benefit from the palliative care program, but because we have set resources, we're not quite able to do that. So the criteria for enrollment is listed here on the slide. The person needs to have a life-limiting illness, which is in the advanced stages of progression. They have to have a prognosis, which is an estimation of survival of 6 months or less. In palliative care, we do know that unfortunately we're dealing with a disease that cannot be cured, and we know this illness will progress over time. And often at that phase, medical management and medical optimization are becoming less and less effective or less tolerable to the individual. So essentially, we know that that disease will progress and cause or contribute that person's death. And so when we think about prognosis, really we're evaluating the circumstances at hand and trying to determine if it's more likely that we're counting lifespan in a number of months rather than a number of years. The third criteria is that the person needs to be agreeable to palliative care involvement, have to be open to discussions, seeing and being assessed by our clinical team members. They would need to no longer have any aggressive treatments ongoing or planned. The main thing that we're highlighting here is intravenous chemotherapy. So it's not that because someone's receiving chemotherapy, they're not ready for palliative care. It's more about the extensive supportive needs that an individual requires when they're receiving this type of treatment. There's a lot of specialized care and assessments and planning and clinical expertise that's required to provide that type of comprehensive care. And so generally, you just want the oncology team to really provide that immersive clinical care, support, and management. So someone receiving intravenous chemotherapy would not be eligible for enrollment on program, but of course could still be supported through the consultation service. I will say there are some oral chemotherapy medications and hormone treatments that have a smaller side effect profile. And so there is a list of some medications that somebody can be on and actually be approved for enrollment on the program. They also must have chosen a palliative focused approach to care. So within our region, that refers to advanced care planning level M or level C, which I'll explain just a bit more on the next slide. So advanced care planning is a process that helps outline an individual's wishes, their values, their goals, what they want and what they don't want for their clinical care. Particularly with a life-limiting illness, it's important to establish what someone's goals are and then to form and provide their care around their wishes. Within the WRHA, there's 3 levels of care that somebody can choose from. So each potential level kind of progressively encompasses more and more possible escalation of medical treatment, more care, testings, interventions, etc. Deciding what someone's level of care is and how they want their care to be managed is really important. It helps us to get a better understanding of what the individual is willing to do, go through, take on to try to achieve the hoped for benefit on the other side of that test, treatment, or intervention. So if we look at the 3 levels of possible care within the WRHA, Mike, if you don't mind. So there's ACPC, M, and R. And again, that progressive escalation of potential care and interventions as you go through the levels. So you can consider care on a spectrum of, say, A to Z. So with the maximal escalation of care all the way up to intubation, ICU admission, attempted resuscitation being on one end, and on the other end is comfort-focused care, maximized symptom management with interventions to support that, but usually with the general understanding or focus on limiting invasive treatments. So kind of 2 ends of the care spectrum. So we just discuss with the patient in the context of their disease, what their wishes are, and then a level is selected. To be enrolled in the palliative care program, you would have to be ACP level M or level C. And that's just really to make sure that the individual's goals of care can align with a palliative focus to care, can align with what the program supports can provide. So the next slide talks about our interdisciplinary care team. We're really, really lucky in our region to have a lot of different team members with different clinical expertise that all work together to meet the comprehensive needs of patients and families. So if we just click, we have community palliative care nurses. So they are the main face of our team. They are the individuals that are in the community, I should say, are the main face of our team. They are the ones in the homes with patients and families doing clinical assessments, checking medications, assessing for symptoms, the home environment, coping, all of those things. Our nurses are grouped into different areas of the city. So normally patients and families are able to see and meet about 1 to 3 nurses fairly consistently. We also have case coordinators who are basically coordinate care for individuals on program across care settings. We know that individuals can intersect the healthcare system in many different areas, at home, an emerge visit, admitted to a medical unit, surgical ward, hospice, etc. So our case coordinators follow their care along in all of their care settings and become the most consistent person involved in their care and understanding their circumstances. They are accessible by phone to patients and families, Monday to Friday, 8:30 to 4:30. And then we also have an after hours team available to capture issues evenings, weekends, and holidays. We also have clinical nurse specialists like myself. We have a small group of us who help with complex care needs and also general team support. We also have psychosocial specialists. We have 2 within our program. They are very, very busy. They're social workers who have master's degrees. And they provide the intensive counseling for patients and families. So the kind of psychosocial emotional support beyond what any of our kind of nurses or physicians can provide. They can follow patients and families along for a period of time and help them with their psychosocial needs. And they also help with supportive resources and some financial elements as well. We have a home care component built in with our program. So we are so lucky to have healthcare aides and direct service staff who go to the homes in the community setting. They're also obviously present in the hospital setting, but for our community-based group, they go to provide physical care and support activities of daily living in the home. Most patients have access to a maximum of about 50 to 55 hours of home care support per week, which is a lot of support and can really help keep somebody at home ongoing for long periods of time. But your 55 hours divided by the 7-day week, you can kind of see that it's not going to be anywhere close to 24-hour supportive care. So a lot of the care in between those times falls to caregivers and families. We have palliative care physicians, so specialized in palliative care, very focused on symptom management, complex needs, and general clinical needs of patients and families. We also have volunteers. So we draw from the really great team of Palliative Manitoba to utilize volunteers for companionship, support, and bereavement for our patients and families. And the other piece that I wanted to mention is we also have the pediatric palliative care team. So I'm not able to go into great depth about what they offer just because of time, but they do have physicians and one clinical nurse specialist that provide comprehensive supportive needs to the pediatric palliative care population. All right, so enrollment benefits for people who meet that eligibility criteria and are formally enrolled on the program. The benefits that they receive, the core benefits, are listed here on this slide. So again, we don't replace the involved clinical team. We try to work alongside them as much as possible. They know their patients very well, so we work collaboratively. But there are some cases when we might take over care more immersively, depending on what the overall needs are for that individual. So it's an application process. So the care team involved can send us an application, which would be reviewed. Sometimes we can just tell from the paper application if the person's appropriate or not. Other times we also do an assessment and go meet the individual and review things in person. The application can be submitted from the involved healthcare team, but also the patient and the family can also say to the healthcare team that's there, we really think palliative care would be helpful. Can we get them involved? So we see and support individuals in whatever care setting they are throughout the WRHA. If they're at home, if they're in a personal care home, a group home, a hospital, etc. Wherever they are, we can go and see them. Again, we have a 24-hour access to support patients on program. So our after hours coverage, it's one nurse who's on coverage for the entire city of Winnipeg. So again, keeping in mind the high population that we have in Winnipeg. So they do a lot of troubleshooting by phone, so giving guidance and suggestions by phone. They might go out to the home to do an urgent after hours visit if the situation is complex and the needs are acute. They might schedule an extra visit for the person the next day. They might give them direction on the phone and then call them back in an hour to follow up. They might offer them an admission to the unit or tell them to come into hospital through the emergency department. Depends on what's happening, but it's really beneficial for our community-based patients to have this sort of safety net of always having somebody to call if things come up, even if it's 2 in the morning. Bereavement support, we do have our nurses, they do a follow-up bereavement support visit after somebody has died on program. So they check in with the family and the caregivers to see how everybody's coping and how things are going. And then we also send out a package to the family after somebody has died, and we can have our psychosocial specialists follow the family for a short period of time. And then if they need continual support, we would transition them to a sort of more long-term supportive bereavement service. The next slide, we're talking a bit more specifically about some of those listed benefits when you're enrolled on program. So we have 45 beds for enrolled patients across 2 different hospitals. So we don't have as many beds as we would really need or like to have. So we do have to use them in a judicious way to help make sure there's as much access as possible to as many individuals as possible. So we do use them for short-term stay. The main 2 elements for short-term stay would be uncontrolled symptoms. So if somebody's having really bad pain or nausea or shortness of breath, having difficulty getting a handle on those symptoms in their current care setting, they can transfer to our unit for acute symptom management. The other criteria would be end-of-life care. So if someone's in the final weeks or sometimes days of life, they can transition to a palliative care unit for that sort of more intensive supportive care. We often have open beds available so people can transition pretty smoothly right to the wards. But if there is not an open bed available, then we use a waitlist system. So the individual's name and their needs get put on a waitlist. We have a small team of staff who triage and monitor that waitlist. And as beds become available, they can move into that open bed. If somebody's still in their current care setting waiting for a bed, think of like a hospital environment, that's okay. They have their supportive team available. They have their regular healthcare team accessible to them. If somebody is at home waiting for an admission to a hospital bed, they're kind of considered a bit more vulnerable just because they don't have healthcare providers on hand and a call bell to call and hit it for a nurse or a healthcare aide. So we do consider that in our flow and transition of patients to the units. And if needed, we can try to put some additional stopgaps in place at home to help that person stay at home safely until a bed becomes available, or the instruction might be for them just to attend to hospital through the emergency department or urgent care, and then our team would connect with them there and then figure out next steps. We're also going to talk about hospice. So we have 2 hospice sites in Winnipeg, 16 beds available. Locally here, we refer to hospice as residential live-in facilities. So sometimes a person doesn't need the intensive supportive environment that a hospital provides, but they might not be able to get back home for care because their care needs are maybe too complex or their needs are quite high. So a hospice becomes a nice kind of middle ground for those individuals. The general criteria for hospice enrollment is there on the slides. Our 2 hospices are 2 freestanding buildings with really great grounds, a lot of greenery, both close to a body of water, so very scenic and very kind of home-like. They all have private rooms for the residents. Healthcare staff are there, nurses are there, meals are prepared on site, and they do have a daily cost with them, which is referred to as a per diem, $30 a day. The other thing I'll say is that it's because it's a freestanding building not attached to like a hospital, their infrastructure is a little bit different. So they don't have kind of acute or immediate access to things like blood work or diagnostic scans, CT testing, X-ray scans. Those elements of care can absolutely be done, but it just takes a little bit of planning. And so we always have to consider the type of patient we're sending to hospice and make sure that their care needs can be matched and met with what hospice can provide. A physician is available 24/7 at hospice by phone, and they also attend rounds weekly and also are available acutely as needed for issues and concerns that might come up. So this slide here is just really trying to capture the kind of layers and complexity for care at home. So we're going to just go through a really quick scenario, trying to capture all of those different components to give you guys a picture of kind of a synopsis of what care at home might look like for somebody on our program. So we're going to be talking about patient X. So you can imagine the nurse who goes to the home to go see this gentleman. They might be as they're on their way in, maybe the healthcare aide is on their way out. They just helped patient X with his AM care, his sponge bath, getting ready and dressed and washed for the day. In the nurse's assessment, it's noted that patient X is having worsening symptoms over the last 1 to 2 days, which are new and different from his usual symptom pattern. So the nurse basically discusses with him what the possible approaches are in the situation. Do we want to do some investigation, some diagnostic treatments in hospital to get more information to better understand what's happening for him and what the changes that are happening? Or do we just treat the symptoms alone and maximize his comfort? Or if things are really complex, maybe he needs an admission to one of the palliative care units for a short-term stay. Mr. Patient X's son is also present in the home, recently came from out of town. He hasn't seen his dad in 4 months. So he's having a hard time adjusting and understanding all of the changes that his dad has gone through and how different he looks. He's quite emotional and upset throughout the visit. And so the nurse rightly offers psychosocial support for him, which the son is eager to receive. The nurse would maybe call the palliative care coordinator and provide an update on how patient X is doing today and the changes. And then as they discuss the situation, they decide to add an extra nursing visit for him the next day for additional follow-up, rather than waiting for his normally scheduled visit, which is 3 days away. They patch in the palliative care physician to that phone call and review patient X's symptoms. He's not yet decided how much he wants to escalate his care, but in the interim, it's really important to get his symptoms better controlled. And so the physician makes some medication suggestions for his symptoms. The nurse also orders a hospital bed and a commode, and is going to make sure he's more comfortable at home, and is going to ask occupational therapy to come and see him this week to see if there's other elements or equipment that he could benefit from. Patient X's wife later that evening calls the after hours team, and because the meds have been delivered to the home, but she can't quite remember the nurse's instructions about what she needs to do with the medications and if they should start today or tomorrow. So the after-hours nurse reviews patient X's file and outlines with the wife what the medications are and goes through the plan again with her as a reminder and provides support by phone. That nurse also then looks to make sure that he has a letter of anticipated death on file. So on our program, this is a document that we utilize for patients with a limited prognosis with a goal of a home death, and who are receiving support from our team. So we outline all of that information and include the funeral home that's involved in their care. And one of our physicians will sign that letter and say, hey, I'm the person to talk to if there's any questions or concerns around patient X's death at home when it occurs. A copy of that letter is in the home, a copy of that letter goes to the medical examiner, and a copy goes to the funeral home involved. Having that letter in place also allows the funeral home to come directly to the home after patient X dies to retrieve his body, rather than the family having to call 911 and police attend to the home, fire department attend to home. The letter of anticipated death is a document that we use to help kind of have a clear path for death at home when it occurs. So care at home can be straightforward, can be quite layered and complex. That's just a quick synopsis of kind of a scenario that might happen on any given day for our patients and families. And so as the team involved and having helped other patients and families kind of on the pathway of palliative care trajectory, it's our job to kind of plan and look ahead and to guide them, provide information, education, and support to make sure that things go as smoothly as possible. So the next couple of slides is just quickly looking at some of the stats for our Winnipeg-based program with our 2020 to 2021 fiscal year. Just to kind of give you a sense of the volume of patients that we support. This is for enrolled patients on programs, so we definitely support another large volume of people through the consultation service, but these are the stats for those enrolled. So we had about 1,500 new patients accepted onto our program during that time. We had 470 patients registered on our program at any given time across healthcare settings in the WRHA. We can have up to 140 new referrals per month, and the median length of stay on program is about 40 days. So interestingly, we definitely have patients who are with us for 6 months, sometimes longer, definitely sometimes longer. But the 40 days just kind of highlights that things are sometimes can be skewed because we often still do get really late referrals for individuals, sometimes in the final days of life, final weeks of life. So I guess when you put all the numbers together, our length of stay on program is 40 days, but we definitely have people on program for many, many, many months. So location of death for patients enrolled on program. I think most people know that generally speaking across Canada, there is a strong desire for people wanting to die at home and have a home death. On our program, that was achieved for about 45% of our enrolled patient population, which I think is really great. There's a lot we can do to support home death, and it's possible in many, 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 many scenarios, but not all the time. So alternate care settings are really important and valuable as well. On the palliative care units, I think was about 45% of deaths for patients enrolled occurred on one of our units. Hospice on the top there in the green was a smaller percent of individuals dying there, which somewhat has to do with the small number of available beds across the region. You can't have a lot of deaths occurring in the same volume as other locations when you only have 16 beds available. Acute care in the blue, so any of our community or acute care hospitals, and then PCH or long-term care in the purple towards the bottom. So a very small group in that care setting, and that's because we don't often formally enroll patients in that care setting. We often utilize our consultation service to follow them along, and that's really because a lot of our stated benefits to program, like drug coverage, home care, those things aren't necessary when they're already in an immersive supportive environment like a personal care home. The last slide is stats for patient prognosis. So we definitely have a large group that have a cancer diagnosis, but we also have about a quarter of our total group having a non-cancer diagnosis. So that might be neurodegenerative conditions, and also that's our chronic disease patient group. So heart disease, lung disease like pulmonary fibrosis, kidney failure, etc. That population has increased on our program over the last couple of years, which is, I think, really great and really wonderful. There's often, although, a bit of struggle around determining when that 6-month prognosis is kind of in the time frame for people with chronic disease or non-cancer disease. It's hard to always know when the right time to enroll them is, just because of the somewhat unpredictable nature of their disease course. So often there's that acute exacerbation with the potential of recovery, but often that recovery is not as high as their previous level of function. Not always clear how much recovery they'll get or when their next exacerbation might occur. So that kind of unpredictability that can come with the course of disease and illness can make it a bit tricky to know when someone's in that 6-month prognosis range. But of course, we do the best that we can, put all of the clinical pieces of information together and try to delineate when that time is and enroll as many people on program as we can, so that they can benefit from the supportive, insulative support that our program provides. And again, the rates of enrollment have increased over the last couple of years, which I think is really important. And that's my last slide. So I'm going to turn it over to Brenda now to talk about one of the rural healthcare regions within Manitoba.
Okay, well, thank you for inviting me to be a part of this presentation today, and being able to give you a brief overview of our rural program. There are 5 health regions, as Ogechi mentioned, also with the shared health. We are just one of the 4 rural programs that are out there, and they all are a little bit different, I think. So this is just the Prairie Mountain rural program that we're going to talk about today. Okay, so Prairie Mountain Health was established in 2012 when it was amalgamated. The Brandon region, Parkland, and Assiniboine regions were amalgamated to one region. We cover 169,000 square kilometers, so we're quite a large area. Population is the 169,760, so 13.2% of the province. We have 20 acute sites, 43 long-term care sites, 9 transitional sites, 6 primary health centers, 1 primary care center, and we have 38 EMS facilities. And the EMS just became a part of the Prairie Mountain program not long ago. So they can actually come from, depends who's on call as to where they come from to transport clients. The transitional sites in our areas are used for clients that are often waiting for personal home care placement, but maybe don't require an acute care bed. But in most of those sites, we do have mostly just one dedicated palliative care room that they can utilize. And often our palliative care client will stay in that room until the end of their life or until their death. Okay, next slide. So the definition that we use in Prairie Mountain Health for palliative is basically similar to most of the other ones. It's an approach to the patient care for patients facing a life-limiting illness that is not curable. It's a commitment to whole person care that helps to relieve suffering and improve quality of life until the end of life. So kind of what Mike talked about was the whole suffering, like it's not just physical pain, it's all the other kinds of pain as well. And we really focus on palliative care being a form of care when focus is no longer on a cure. Okay, next one. So palliative care in our region, it's delivered all across PMH. In Brandon specifically, we have 12 dedicated palliative care beds in the Assiniboine Center. So we have the main hospital, and then we have an Assiniboine Center that's another, does some long-term care. It also has a medical unit, but there is a palliative care unit there. So often people will be admitted there for symptom management, if they're having concerns with pain or nausea or whatever it might be. Maybe get those symptoms under control and go home again. or it can be a place that they can go for the end of life if they're not able to stay home or choose not to stay home to die. The one thing about the unit here is that Ogechi had talked about the goals of care, the ACP goals of care. So to be admitted to the palliative care unit in Brandon, you must be a comfort care or medical care. If you're still wanting resuscitation, then you'd be admitted to another acute care bed somewhere in the facility, just not to the palliative care unit. And if those 12 beds happen to be full, often people will be admitted to an acute care unit and then transferred over when a bed becomes available. Unfortunately, we don't have any hospices in our region. Often, if clients are stable and they're in an acute care facility, they may be paneled for PCH, all depending on where they are in their illness trajectory. We do care in the homes, just like Ogechi had mentioned as well. Our increase in home deaths has really gone up with COVID this year, due to due to the visiting restrictions in facilities, people choosing to stay home to die. So we do lots of home deaths. In our rural facilities, the acute care centers throughout our program, we do have usually 1 or 2 dedicated palliative care rooms that are funded. They're funded acutely, so they're not funded as a palliative care bed, though I should have mentioned the Brandon ones are funded as palliative care beds. So that is the difference. So these rooms are rooms that are perhaps larger to accommodate the comfort of families as well. If that room is occupied and the client is needing to be admitted, they will still be admitted to the facility in an acute care room and receive palliative care. Because we must remember that palliative care can be done anywhere, right? In any setting. It's not just about a room. So we do have local palliative care volunteers that do lots of fundraising throughout the year to help decorate or to provide the decor and the furnishings for the palliative care rooms. And often there's a family room adjacent to the actual client room where families can go to, maybe rest, have a little bit of a reprieve. They can have their make light lunches in there, coffee, tea, all those kind of things. So it's just kind of makes it more like a home-like environment. And that's also a lot of that, the furnishings in that room are provided by the fundraising by the local palliative care groups in the community. Okay, next one. So our eligibility is a little bit different in our program. The only criteria to come on our program is that the client must have progressive life-limiting illness that cannot be cured. Prognosis is not a criteria, although we request that an estimated prognosis be stated on the referral form when we receive it. Our belief in our program is that the earlier we get referrals, it may enable clients to stay home longer with increased quality of life and have some of the supports and resources to help with their needs earlier. Another difference in our program is that they can be receiving a chemotherapy treatment if it's of palliative nature. So if it's of a curative nature, obviously they're not on our program, but they can still be getting chemo treatments and be on our program. And a lot of the common diagnoses that we see are terminal cancers. That what counts for the majority of our referrals that we get, but we do get people with motor neuron diseases, things like MS, ALS, Parkinson's. We do have end-stage congestive heart failure, end-stage COPDs, end-stage renal failure if they're not pursuing dialysis treatments, and end-stage dementias. The other thing that is different in our program, and Ogechi had mentioned the different goals of care. So in our program, you can have any goal of care that you like, whether it's comfort, medical, or resuscitation, and still be on the palliative program. But we do have lots of conversations with people around those goals of care once we meet with them and they're reviewed. Okay, next one. Okay, so anyone can make a referral to our palliative program, but we do have to have a physician sign that referral form. And that is just, we need to have it confirmed that it's actually a palliative diagnosis, and we need a physician on board to prescribe orders for meds and do the follow-ups. So we get lots of referrals from physicians, nurses, home care, social workers, family, friends. Patients refer themselves. We do have that happen. Sometimes pastors, spiritual care in the community will refer, and we do get referrals from cancer care. And that's just it's hard to see, I think, but it's actually our referral form. So on there, it's just like check boxes where they can just kind of give us some basic information. And then usually what we do is we'll just follow up with the client to get the more detailed information, or the physician. Okay, next slide. So our team is relatively small in PMH. We have our manager that manages the unit, the palliative care unit in the Brandon Hospital, and our regional palliative program. We have a regional palliative coordinator who is a full-time position, and she's based in Brandon and covers the Brandon area and close proximity, so just outside the city limits. And then we have 3 regional palliative care clinical resource nurses, which I'm one of. And as you can see, those are the areas of coverage that we have. So I don't know how familiar you are with the province, but our areas are very large and dispersed. So there's lots of driving time in our day sometimes. All our CRM positions are 0.8, so we all work just 4 days a week. And we do not have any coverage on weekends or stats, and we do not have any 24-hour coverage. So often when we're not available, people do have to seek treatment at emergency. Sometimes they can call up to the palliative care unit if they're in Brandon and they're on the registry there. They can have a nurse speak with them if it's in the middle of the night, maybe if it's a pain management issue or something like that. We also have a regional palliative care volunteer and bereavement coordinator. She's a 0.6, so works 3 days a week. Okay, next slide. So just our different roles in our region. So the role of the palliative care coordinator and CRNs, we receive the referrals and do our own intakes. So according to our areas of coverage, we have what we call a shared fax. All the referrals come to that fax, and then depending where they live is where that referral will go to. So we do all our own intake. We'll register the client with the program and the palliative drug access program, if applicable. So if they're taking, like when mentioned, they can be on chemo treatments in our area. But if it's an oral chemo treatment, then we can't enroll them on the palliative drug access program because the coverage is better through cancer care financially for them. If they are receiving an IV chemo through a port, they can still access our palliative care drug access program and have their medications covered. We do, usually once we get the referral, we'll call the client and we'll talk to them about our program, let them know what's involved, make sure that they're okay with being on the program. And then we may do an initial visit with them. So a lot of those visits are done in person, although we do offer phone visits and virtual. So during COVID, we did probably a lot more virtual and phone than in person, of course, but now we're starting to do a combination and seeing more people in the home now. So a lot of our role is supporting people with pain and symptom management. So we help resource out with their physicians as to what is going to help with their symptoms so that their quality of life is improved. We help identify other resources and supports to help them as well as their families in their home and offer to make those referrals to those programs. So some of them would be things like home care, OT, PT. I think I've covered that maybe in one of my other slides as well. So we do help support clients with their physical, their social, emotional, physiological, and spiritual needs as best that we can. We also serve as a resource to staff in hospitals, in the home care programs, and the PCHs. We provide education where needed. We get requests to go do education for the healthcare aid and nursing programs. And also we do yearly conferences in our region. So our program puts together one is in March and one is in April, and one is a professional conference. So we'll have speakers, and often they're palliative physicians out of Winnipeg and such that come and do talks with us on palliative care. And then the one that we usually have in April is a psychosocial. And that one is for anybody that's interested in palliative care, whether they're in a volunteer role or they might be a family member. We have lots of speakers come to that as well. Although with COVID, they've been on hold for a couple of years. So we're hoping, I'm not sure if this year, but going forward that we'll be able to have those again. Okay, next one. So this is Carla's role, the role of the volunteer and bereavement coordinator. She oversees and provides supports to 21 groups of volunteers across PMH. So she has a lot of work to do with the volunteers. She provides support to them through fundraising, awareness, education events, direct client support services. She kind of helps with she does help with the training, recruitment, and ongoing retention of volunteers. And right now she's doing a re-onboarding with them because they have not been able to do the volunteering through COVID, but that's coming back hopefully. So she's getting lots of that prepared. She does bereavement support. So when someone dies, we send the family information to Carla and then she'll do a follow-up. So she'll send them a package out in the mail, and then she does a follow-up with them at 6 months and at 1 year, just to see how they're doing. If there's other resources that they're needing, then she'll direct them to those. We have a Camp Bridges. It's a grief camp for kids in our region. It used to be bi-regional with another health region, but now it's just going to be run by Prairie Mountain Health. It's for kids that are 7 to 15 that have lost a loved one. So the loss doesn't have to be just to a palliative diagnosis. It might be they've lost a loved one to suicide or a trauma. It goes from a Friday evening to a Sunday at roughly noon. And it's done at one of the camps throughout our in our region usually. We do a lot of memorial activities at that camp. So, and we do memory boxes, photo frames, all those kind of things. It gives the kids a chance to really get together with other kids that have experienced a loss. And we've been told that some friendships have been formed and actually stay throughout years after. We also do fun activities. So it's not all about the grieving. They get to do fun things together too. So things like might be swimming, horseback riding, canoeing, just whatever camp we're at that has those activities. And it's all funded by donations. So we get lots of donations from the community groups and people that are interested in helping us run the camp. Okay, next one. So I kind of did talk about some of our roles, but we use a real team approach across, like with lots of other partners. So in our program, we use home care a lot, especially, well, obviously if they're in the home. We don't have any designated palliative care nurses, so we utilize the home care nurses. The home care program also provides healthcare aid assist for clients' personal needs, and often the nursing supports are there to help with the symptom management, along with working with us to do that. We support facilities in hospitals, acute care centers, and long-term care. So if the client is in hospital, we often will go there and see them. We provide resourcing for symptom management to staff in hospitals, so they can provide that care. We do on and off reserve services in our region. A lot of the reserves themselves have their own nursing staff and home care nursing on reserve. So often we're just a resource service to them. Although if they're needing us to, or that's something they're wanting, we will go on and do visits there. And like I talked about, we do facilitate deaths in a home environment. So we do a lot of home deaths, and I have our home deaths increased with COVID. I actually have a stat here. So in 2019 to 2020, the number of home deaths went from 28 to 79. And that isn't completely accurate because we don't have all the Brennan stats, because the computer system that we're using wasn't able to pull those off at this time. So it would even be more than that. We have physicians and nurse practitioners. So we do not have any dedicated physicians in our program. We use the client's primary or family practitioner or nurse practitioners, but they often will call the WRHA palliative doctors, which Ogechi had mentioned about the consultation service early in her presentation, if they're requiring any further assistance with managing the client's care, and that is accessed. Okay, next one. So some of the barriers and limitations in our program is the logistics. Of course, the physical logistics. Our areas of coverage are very large, often depends on weather, right? Out in the rural here, some very remote areas, we're driving down lots of gravel roads and such. Virtual services and technology. So like I mentioned, we used a lot of that during COVID and still are. But we're finding that the internet is quite poor in some of the rural and remote areas, as well as a lot of our clients may not have the technical skills or ability to do that. So we do provide a lot of telephone support as well. Accessibility to services is often limited. Sometimes we have resource shortages in home care and other disciplines to support clients at home. Often, they may have to be admitted to facility to meet their care needs. We have had some medication shortages, more so during COVID, but we're still seeing them ongoing to support some of the symptom management in the home. Another thing is that can be difficult is some of our clients in rural areas don't have access to transportation to go to appointments. It's costly for them to maybe go stay elsewhere to get their treatments. Telehealth is often used now, especially with oncology, for their follow-up appointments. So that is helping a lot of our clients. Okay, last slide. So just my experience personally as a palliative care provider, it's been really rewarding for me. I find that, I think with all the education and conversations that we're having, death is becoming a more natural subject to talk about. There's still a lot of stigma out there, right? I don't know if that's the right word, but death is a part of the cycle of life, and I think it's something that we really need to address. We're trying to incorporate learning earlier with children, teaching them about death. We do have death cafes that are taking place in our region, and those are, they're very informal. You don't need to have any formal palliative care experience. They're often done in many different settings. There's usually just a facilitator that's interested in palliative care that will meet with people, over coffee, and they just let people talk about their experiences with death or their comfort level with death. It's just a really open forum. And I think it's really helpful. We're seeing a lot of good success with that. It's just funny that I often, when I phone people and I tell them that, I've got their palliative care referral, and their response to me is often, I'm not ready for that yet. Or they'll say things like, is my bed ready for me then? So I think, as Mike and Ogechi mentioned before, is letting people know that palliative care doesn't mean that you're going to die right away. It's about enhancing your quality of life, helping you live the best quality that you can while you're going through your illness. And I think that is the most important thing that we can get out there. Okay, so that's very brief. There's lots of other details that I could go on about, but for the sake of time, that's just the overall PMH program. Thank you.
Well, thank you for the presentation by this group. It's been very thorough and I've learned a lot. And once again, I'm reminded that every province has their own system and limited resources. One of the things that one of our panels wanted to ask was that for Ogechi, you had mentioned that people can only qualify for this service if their prognosis is for 6 months or less. So does that mean that if somebody is at the very beginning stage of their chronic illness, that they can't sign up and for services, so that it keeps them and maintains them in a better frame of mind?
So that person would have access to our team, our expertise through consultation services. So we would be able to, if they're within the WRHA, we would be able to meet them, see them, have conversations, follow their clinical care along as needed based on what their symptom needs are, their emotional needs are, their questions, concerns. And that ongoing follow-up can occur kind of indefinitely, as long as there's things that need to be supported and addressed. And that consultation can occur in any care setting as well, in hospital, in the home, and a long-term care setting. Anywhere where that person is, we can see and support them there in collaboration with their established care team. The prognosis piece is one of those factors where if the person is not within the 6-month range or close to, maybe it's 7 months, maybe it's 8 months, but kind of the thought that we're counting their prognosis in months rather than years, that is required for the formal enrollment on program. And that's just because, again, set resources. If we took everybody as much as we would like to on the program, then the service delivery would suffer. So that person who's very early on their disease onset with chronic illness can definitely utilize consultation services. They just wouldn't get some of those other elements of care, but they still would have drug coverage through the normal pathways. They would still have access to regular home care. You can receive home care without being enrolled on the palliative care program. So the 55 hours of support is absolutely available for you in your home to help meet your supportive needs. And then our role just shifts a little bit through the consultation.
Okay. All of you have touched upon about how COVID has impacted on your services. I guess, if there was a silver lining out of COVID, what would you say that would be? Mike?
Yeah, so in terms of our support services and education, one of the benefits definitely of transitioning to virtual delivery has been our ability to connect with people all across the province, all across the country. Sometimes when it comes to grief support and education, we're creating a vast network professionals and volunteers now that hopefully will stay in contact after this pandemic is over. But certainly, you know, while that has been, you know, one of the benefits, not being able, just in terms of our perspective from Palliative Manitoba, not being able to, you know, be in person with particularly our kids and teens grief support groups. You know, people really benefit from you know, being in the same room with each other, and you know, just you know, being with each other, like playing with clay or Lego or drawing. That's when conversations about grief and loss really take place in that organic way. And I'm just finding, you know, doing the program delivery over a screen like this, it just really complicates things, and it's just less intimate when it comes to the kind of support. But for sure, there, in terms of connection, there are great things happening, reaching people that we haven't reached before. But you know, like Brenda mentioned, internet access and quality of internet is also an issue that we've been dealing with too, and that needs to be addressed if we're going to continue to support people virtually.
Okay. I was just going to say to our audience, you know, feel free to put your questions in the Q&A box. I'd be happy to read them. I have another one that was sent to me previously. Someone lives out in the rural areas, and I know that Brenda and Ogechi had already sort of touched upon this sort of briefly about how, you know, because they're in rural areas, it's very expensive for them to come into town or into the city center. You know, how do they make sure they still get their resources? I know, I think in your presentation slides, you had touched upon that briefly, but if you're able to, perhaps you can share some of those links with CPFF, and we can post it on our website so that people can go and you know, have a look at it and see how can they access that if they're out in the rural areas.
I can just say, you know, we have lots of, like there's cancer care vans, for instance, in Brandon. There's different local volunteer groups in the communities that do some of the not through palliative, but on their separate programs that will do transportation into, if they have to go into Winnipeg for treatments, or even rural into Brandon. But that's also been interrupted with COVID, so been on hold. So it's been really difficult for people financially to access some of those services. There are different facilities, we can post those for you, in Winnipeg that they can access to stay, like if family needs to stay or they're having a treatment. Some people have to have their radiation done in Winnipeg, so they might be in there for 28 days or whatever it might be. And there's different hotels and areas that they can stay in that are more affordable.
Okay.
But it's still very costly.
Yeah. Okay. Because I know from the pulmonary fibrosis community, especially those folks who live in Manitoba, they often feel very isolated because they might be the only individual patient with that condition. And oftentimes they're not sure who to access for support emotionally, and also comprehending the fact that they will die from this disease, right? How do they manage that with their family? So that's one of the reasons why at the CPFF, we've been hosting palliative care to explore different options, to see where the gaps are, and to motivate people how to maybe contact their you know, provincial ministers and the federal ministers about, you know, more funding for this area, because many people are very concerned that with this disease, as it progresses, they're going to need to access those services, right? And if you don't have anyone to look after the care on the weekends and statutory holidays, that can be very difficult, right? It's a traumatizing condition to have to go through, but then to not know, having anybody at the other end of the line to help them, that's very you know, traumatic. Yeah. Are there any last things that any one of you would like to add before we end our session today?
Just want to thank you again, Sharon, and the foundation for inviting us to do this. Like I said, it's always a pleasure to talk about palliative care and this approach to care, and to try to create a more grief literate and death literate community. Just want to share a really beneficial resource with everybody that everyone can access online. It's virtualhospice.ca. If you haven't already heard of it, Canadian Virtual Hospice is an international website and resource, but they're based here in Winnipeg, and we're very proud of that organization. There's a really amazing function on their site, a portal that is called Ask a Professional. So anytime you have a question about your disease course, about end of life, dying, grief, bereavement, anything at all, you can type it into that portal, and you'll get a response from a real professional, a palliative care professional, who will get back to you within a few days. So it's a really great resource, and there's so many other portals that they have created, like mygrief.ca. That's a great tool for grief and bereavement. It's a modular program, so I recommend everybody just explore virtualhospice.ca.
Thank you very much, Mike. Ogechi and Brenda, thank you all of you for coming on today. This is a very valuable resource webinar that many of our community folks will be accessing in the futures to come. Thank you.
Thanks.
Thank you.
Thanks so much.